Good afternoon, all of you. Welcome to the 23rd edition of the Healthcare Insight series um, from Healthcare Sector Skill Council. I'm Dr. Megha Agarwal from Healthcare Sector Skill Council, and I'm very glad that we are putting up a monthly webinar under the Healthcare Insight series with our valuable industry partners, giving you some skilling, reskilling, or upskilling opportunities with on very niche areas on specific topics so that you can incorporate that in your daily practices or in your training into your training curriculum. It can boost your respective training methodology or training delivery plan, or it can boost your own practices while you are working in the hospitals. We get to have a good number of participants from across India in our regular webinars, either directly joining in during the webinar or seeing us through our live streaming on our YouTube channel or seeing our recorded sessions on our Facebooks and other social media pages. I'm very glad with this extravagant responses what we got from our audiences. Thank you so much. Today, in our 23rd edition, we have with us a very esteemed guest, Dr. Soutik Panda, Senior Consultant and in charge of Critical Care Medicine, Woodlands Multi-Speciality Hospital, Kolkata. He is a teacher and examiner for DNB Critical Care Medicine course from National Board of Examinations and IDCCM and IDCCN courses from the Indian College of Critical Care Medicine. He is the winner of prestigious Hansraj Nair Award for Best Scientific Paper at the ISSCM National Conference in 2017. He is also recipient of a prestigious Top Gear Award from the R.P. Sanjeev Goenka Group in 2020. He is also the contributor to various national journals, textbooks, and conference books, as well as faculty in various national and state level workshops, conferences, as an AHA certified instructor or the instructor for the FCCS course. His immense areas of interest into the sepsis, ARDS, mechanical ventilation, and antimicrobial resistance gives us the boost with his immense expertise in handling this critical care area, where he is giving us the a very good orientation towards a very important topic for healthcare in our Healthcare Insight series today, where we are going to have a national clinical grand round with Dr. Soutik Pandey, and he is going to give us the evidence-based treatment of sepsis as a topic today in this clinical grand round session. Welcome to you, sir. Thank you so much for taking out your precious time and giving us the time for this valuable topic. Thank you so much.
Thank you, Dr. Megha. Thanks for the kind introduction and thank you for having me here today. Just give me 1 minute so that I can upload my presentation and then we will start right away.
Surely, sir. Over to you. I request everyone to keep up your questions, keep noting down your questions, keep posting that on the chat box. And at the end of the session, we will take up your questions either written in the chat box, and we will give some time to few of the participants to question the speaker itself by unmuting you. You can raise your hands for the same. Thank you for your patience.
I hope my slides are visible.
Yes, sir, it's visible.
Okay, so let's start. So, good afternoon, very good afternoon, all of you. Thank you so much for sparing your valuable time. So, today we have gathered to discuss something that is very important. And in the next 1 hour, I'm going to talk about how do we go ahead in the treatment of sepsis in terms of whatever latest evidence which are available with us at this point of time. So, when we talk about sepsis, we must know about the global burden of this particular syndrome. And this is something that came up very recently in the Lancet Global Health last year only. And they presented the 2021 data, and that showed that back then the total global estimate was around 166 million cases, and out of that, there were about 21 million deaths. Now, having said that, you must remember that at that time we were going through a pandemic. So, obviously, they included the COVID-19 deaths also, because they were also sepsis related deaths, because it was a viral pneumonia that the patient had, and then the patient finally, there were many who finally succumbed to the disease. There is a very recent document that got published this year only, and in fact this month only. In the first week of April, we have this long anticipated, long awaited guideline of surviving sepsis campaign. And in this 2026 guideline, they also have given us a global estimate. And according to this piece of document, now the global estimate of sepsis cases stands around 49 million cases annually, with approximately 13 million sepsis related deaths. So it's quite a number of deaths happening because of sepsis. So almost one death in every five patients still happening because of sepsis. And that's how the Global Sepsis Alliance, which was formed in 2010, they from 2012 onwards, they started following this particular day, that is the World Sepsis Day, which is followed on September 13th of every year. And the entire objective is to raise the awareness about this particular syndrome, so that there is early diagnosis, early treatment, and even the common public is aware of what is all about sepsis. Now, if we look at our Indian data, whenever it comes to sepsis or septic shock, there is a dearth of Indian data. We always try to look at what's happening in the West, where in the Western countries. But there are some valuable studies which have been done in the Indian scenario, and this is perhaps the first one. This is the INDICAP study, and this was done way back in 2010-11. This was a 4-day point prevalence study, observational study, of course, where they wanted to see about this entire burden of sepsis sepsis as well as septic shock in Indian patients, in the Indian ICUs, and almost 120 ICUs participated. More than 4,000 adult patients were there. And since this was just a 4-day point prevalence study, there were some important observations that they had. For example, that during that entire period of study, they found that almost 30% of patients had severe sepsis or septic shock during that particular point of time. Now, since this study was done way back in 2010-11, that time we had this terminology of severe sepsis. But thereafter, in 2015, we had the new definition of sepsis, that is sepsis 3, which totally ruled out this entity called severe sepsis. So now it is either sepsis or septic shock, and there is no severe sepsis in between. But way back then, they had this terminology of severe sepsis. So around 30% of patients had severe sepsis, and by that they meant that sepsis with some form of organ dysfunction there at the background. And almost 37% of patients, they received mechanical ventilation because of the sepsis issue, and 22% they received vasopressors or anatropes. Now, what was alarming to see was that almost 60% of patients without any infection, they received antibiotics. Now, that was quite alarming, because in today's era, when we talk about evidence-based management, we are always thinking about stewardship. So whenever we talk about antibiotic stewardship, as we all know, that the antibiotic supply pipeline has gone dry, and whatever is available in our armamentarium right now, we have to use it very, very judiciously. So using antibiotics without any proper evidence of infection is something that is very alarming. We are simply wasting our valuable resources. So this was one thing that was pointed out in that INDICAP study, that almost 60% patients during that 4-day study period, they found out that they received antibiotics but without any proper evidence of infection. And what about the mortality? In the Indian context, they found that in their point prevalence study, the mortality in septic shock was around 34%. So this roughly corroborates with whatever Western data is available with us. So in septic shock, we know that the mortality can go to the tune of almost 40%. So we are not doing very bad in the Indian context. So From 2011 cut to 2018-19, this was the second edition of the INDICAP study. Again, the same group of investigators, they wanted to see where do we stand exactly almost after a decade from the first study, just to see how things are going on, whether they have gone worse or we are doing a little better than what we used to do almost a decade back. And this was also a 4-day point prevalence study which was done between 2018 and 19. Here, more than 4,500 patients, the number of ICUs which participated all across the country were even more, around 132 ICUs. And here also, they had some interesting observations. So, again, almost 24% patients, they receive mechanical ventilation, 22% receive vasopressors and inotropes. And the mortality, the ICU mortality was around 36.9%. So almost similar to the kind of mortality they saw almost a decade back. But this time, they tried to see what was the most common offending organism behind sepsis. So they found that in the Indian context, it is perhaps the gram-negative organisms which are causing the damage more than the gram-positive. So exactly something that is not the kind of things which we get to see from the West, that they are troubled more by the gram positives. But here in the Indian subcontinent, it is mainly the gram negative organisms which is accounting for almost 75% cases of sepsis. And here also they found that on the study day, almost 70% patients, they received antimicrobials, that is antibiotics, and almost 16% of them, they received 3 or more antibiotics, which was quite a polypharmacy to start with. So here again, when we talk about stewardship, it has to be a guided therapy, a narrow down spectrum. So if you want to avoid polypharmacy, because polypharmacy can lead to an increased healthcare cost, and at the same time, it can lead to drug toxicity as well. So you have to narrow down the spectrum as soon as possible so that you give targeted therapy instead of giving polypharmacy in your patients. So these were some of the data which was first pointed out by the INDICAP 2 study. So INDICAP 1 and INDICAP 2, these are valuable data to have a gross idea about what's happening in India in the ICU context when we are treating patients with sepsis. Now, I was talking about the third definition of sepsis. This came way back in 2015, this document got published in 2016 JAMA, and now we know that sepsis is nothing but a dysregulated host response to infection, and there is a life-threatening organ dysfunction also in the background. And remember that in the earlier definitions of sepsis, when they used to categorize the entire syndrome as sepsis, severe sepsis, or septic shock, and this severe sepsis, which was somewhere in between, was sepsis with organ dysfunction. Now they have removed severe sepsis from the entire spectrum, and now they say that whenever you are diagnosing sepsis, at that point of time itself, there has to be some organ dysfunction in the background. And it is actually a dysregulated host response to infection for which the entire syndrome is happening. Now, when we talk about organ dysfunction, what has now become part and parcel of the sepsis definition is a new scoring system that is called the SOFA, or a sequential organ failure assessment score. And now this score has become very, very important for intensivists because it's a daily scoring system. If the score goes up, you know that now it's a 1 or a 2 or a multi-organ dysfunction that is happening in your patient. If the score is coming down, you know that the patient has started responding to whatever therapy you have given to him or her, and the patient is getting better. So SOFA is a very important score to do in sepsis patients, and it's a daily score. And by definition, a SOFA score of more than equal to 2 is something that is bad, and it is associated with a mortality of more than equal to 10%. And by septic shock, we mean that when the SOFA is more than equal to 2 and the patient has vasopressor requirement with a elevated lactate, and by that I mean a lactate of more than 2 millimoles per liter or more than 18 milligrams per deciliter, despite adequate fluid resuscitation. And here you can see that the predicted mortality in septic shock patients is almost to the tune of 40%. So that is what the Indian INDICAP study has also shown, that the mortality is almost to the tune of 34 to 36% in septic shock patients in the Indian context. So this is the SOFA score which I was talking about. So it takes into account six different systems. In respiratory system, we look at the PaO to FiO2 ratio. In the coagulation system, we look at the platelet count. In the biliary system, we look at the total serum bilirubin level. Cardiovascular system, we look at the mean arterial pressure with or without any vasopressor or inotrope working in the background. In the central nervous system, something that we do daily at the bedside is the easiest form to check the CNS status is the Glasgow Coma score. And finally, in the renal system, you look at the creatinine or the urine output levels in your patient. So these are the six different organ system. And as you can see that the score goes from 0 to 4. And it is the total aggregate of all these scores taken together. And then we do it on a daily basis to understand that whether the organ dysfunction is progressing or regressing with the help of therapy. So SOFA has now become a part and parcel of sepsis definition as well as sepsis management. When you are doing it, actually doing it at the bedside, you must have an idea about the SOFA score. But having said that, this score has got its own limitations. Now, just to let you know that this score has been well endorsed by the Society of Critical Care Medicine of North America as well as the European Society of Intensive Care Medicine. So this score is very well endorsed, and they have identified this as a very important tool to quickly identify patients who are at risk of dying from sepsis, because we know that if the score goes up, the multi-organ dysfunction is severe, and we know that the chance of mortality also is quite high in this kind of patients. So our SOFA can give you a very good idea about expected mortality in your patient. But as I told you that this score has got its own limitation. For example, it does not, although it is a part of definition of sepsis now, but it is this score will never diagnose sepsis, because the kind of score it is, this can you can use this score even in patients of maybe severe acute pancreatitis, or maybe even patients with polytrauma or major burns injury. So this score can be used in any form of in any disease system where there can be involvement of multi-organ dysfunction without any sepsis happening in the background. So it does not diagnose sepsis. And at the same time, it cannot say, since it cannot diagnose sepsis, it cannot say whether this organ dysfunction which is happening is truly because of any infection per se. So this is also another limitation. And thirdly, it will not determine the individual treatment strategies or individual outcome. In today's era, we talk about personalized medicine or individualized care. Guidelines are there to give us a broad layout, but those guidelines are only going to give us a broad layout, and you there, the physician standing there at the bedside, have to put in many data from your patient, and then you have to individualize as per your patient's need. So the treatment strategies for individual patient will be different. So the SOFA score will definitely going to give you a broad layout, definitely going to identify who are the patients who are going to die early, but they will not guide you according they're not going to diagnose infection, or they are not going to give you an individualized treatment strategy. So these are some of the limitations of the SOFA score. So just to conclude about SOFA is that SOFA will definitely help to identify patients who potentially have a high risk of death from infection, but it will not diagnose infection or sepsis. Now, coming to this particular document which got released in the first week of April, just 2 weeks back, we got this document almost after 5 years, because the last guideline came in 2021, and this is the Surviving Sepsis Campaign guideline, a document which is considered sacrosanct by intensivists as well as physicians working globally, anywhere, any place in the world. This document is considered to be sacrosanct. So some of the important changes which get to see in this year's document is that what is very strongly recommended is to enhance the performance. That is, it has to be a multidisciplinary approach whenever you are treating patients with sepsis. A screening tool must be in place so that you can quickly identify those patients who are acutely ill, and there has to be a standard operating procedure for treatment of sepsis. This guideline itself has given us a very beautiful SOP about how to take things forward, giving the highest quality of evidence, whatever is happened over the period of last decade or so, or maybe some of the important trials have come in after the last guideline came into being in 2021, even after that, because research is a continuous process. In the period of last 5 years, we have got some beautiful guidelines, we have got some beautiful randomized control trial, very well designed trials, which are practice changing trials, and the guideline committee has taken into note all those trials, and they have incorporated the results of the trial into this particular guideline. So you have to have some standard operating procedures for the treatment of sepsis, and one has to implement this to get the highest quality of the results. So that is very, very important. So something new this year in this guideline is to create a code sepsis or a sepsis huddle protocol. Just like we have a code blue team inside the hospital who can quickly address to patients who have undergone cardiac arrest, exactly similarly, there has to be a code sepsis or a sepsis huddle protocol where it has to be a multidisciplinary approach at the bedside, where you can quickly diagnose and start the treatment of sepsis following a positive screening result, so that you do not lose on to that valuable time, because you'll get to know about the 1 hour bundle that we keep promoting. Even in the last guideline also, they keep telling us about the 1 hour bundle. What are the things that have to be done simultaneously at the first hour itself, once the screening test is positive and you know that you are actually dealing with a patient of sepsis. Now, also very important is that what to do even before you reach the hospital. So that is also very important. Now they have started thinking about out of hospital treatment also, when the patient is en route to the hospital, either via an ambulance or via flight. Here also they are suggesting that while the patient is in transit, he or she is on the way to a hospital, use a standard screening tool so that you can identify those who will need immediate care as soon as they land up in the hospital emergency. So these are important. And whenever we are talking about screening tool, these are some of the important screening tool that they have recommended using, and these have, most of them have been given by the NHS. They have come from the United Kingdom, like the News 2, or even the SIRS criteria. So they are the ones who they are recommending using any one of these important screening tools, and not so much about the quick SOFA, because the Q SOFA which they promoted in the last guideline of 2021, the Q SOFA had its own limitations, and it has been validated only at the emergency level and not within the ICU. So they are now more into using tools like News 2, or SIRS as a screening tool in acutely ill patients in the hospital. Even they are asking to use these kind of tools while the patient is en route to the hospital. So these are very important. So overall, the good practice statement that comes out of this guideline is that sepsis is a clinical diagnosis, and this should not be ruled in or ruled out using either a single biomarker or a diagnostic test. So it's an absolute no if you are diagnosing sepsis on the basis of a single test or a single biomarker. So it is an absolute no. It has to be well corroborated. The clinical examination, a well focused history, a clinical examination, then well corroborated by some of the biomarkers and other laboratory diagnostic tests. Everything has to be taken together when you finally arrive at a diagnosis. And while you are doing so, the resuscitation process has to be on. You just simply cannot wait to make a diagnosis and then start resuscitating the patient. So that is very important. Otherwise, you are going to lose out on that vital time. So whenever I am telling about all the screening, this is just one screening tool that I can show you today because of the lack of time. This was the new score, where you can see that 6 physiological parameters have been taken into account, starting from respiratory rate to the oxygen. This is very, very simple. These scores were actually devised for the bedside nurses so that they can quickly pick up the red flag signs in their patient, and they can immediately raise the alarm and start the treatment. So oxygen saturations, or whether the patient is on any supplemental oxygen or not, whether there is a temperature, the systolic blood pressure, the heart rate, as well as the level of consciousness, everything has been given a point of starting from 0 to 3, and then you do the aggregate. So an aggregate of 1 to 4, the clinical risk is low. Aggregate of 5 to 6, it's a red score, the clinical risk is medium, and 7 or more makes it a very high clinical risk. So this was the original new score, and they redeveloped it to the news 2, where they included some other parameters, and now you can see that the kind of response that they want to give, like whether it has to be a ward-based response, urgent ward-based response, or the response level has to be even higher, and the patient needs immediate attention, or maybe shifting directly to the ICU or so. So these are some of the important screening tools that you can institute and can start following in your institution, so that you can quickly pick up. You do not miss those patients who need proper care, need more close monitoring, particularly in the ICU setup. So, talking about the 1 hour bundle, which I have been telling so long. So, this is the 1 hour bundle. So, by bundle, I mean that these are some activities which you need to do simultaneously while you are looking at a patient of sepsis or septic shock. So, these are certain things that have to be done simultaneously. For example, you have to measure serum lactate, and then you remeasure lactate after maybe 2 to 4 hours if the initial lactate liter. Then what is very important is send in blood cultures. So you send 2 sets of blood cultures before you start your antibiotic. So it comes within the 1 hour bundle. The first 1 hour, this is very, very important. When once you start seeing the patient has landed up in the emergency, you have started working up with the patient. So these are the few things that you need to do, absolutely. And once you have drawn in the relevant cultures, give broad spectrum antibiotics. So thinking about the possible source of infection, whether the infection is in the lung or in the abdomen or in the urogenital tract, wherever it is, the central nervous system, etc., wherever it is, think about the possible pathogen and then try to cover those pathogens by starting empiric broad spectrum antibiotics. And then volume resuscitation also is very important. 30 mils per kg. Now, there are certain things which have come up in the new guideline that I'm going to show you, but the 1 hour bundle still stands true, that 30 ml per kg in the case of hypotension, and if the initial lactate levels of more than 4 millimoles per liter. And this 30 mils per kg has to be finished within the first 3 hours. So that is very important. And then vasopressor administration, if the hypotension still persists even after volume replacement, because your target mean arterial pressure has to be more than 65 millimeters of mercury. So this is 1 hour bundle, and by zero time, we mean that the time of triage at the emergency department, or from the time the sepsis criteria recorded in the medical document. So that is the zero time. So once that zero time is being hit, you start calculating 1 hour from that. So this is the entire set of things that you need to do simultaneously if you want to complete the 1 hour bundle. The 1 hour bundle was well promoted in the last guideline, also 2021, and they have kept it intact in this guideline also in 2026. So these are some activities which are very important even today. So when it comes to screening, there are two different ways of looking at patients with sepsis or septic shock. One is possible sepsis, where you are still not sure whether you are actually dealing with a patient of sepsis or some other non-infectious cause of any kind of acute illness. And the other thing is whether it's actually a probable sepsis or a definite sepsis. So if it is a probable sepsis or a septic shock, that is a definite sepsis, then administration of antibiotic as early as possible is very essential. And the time that has been given is within 1 hour of time. But if it is a possible sepsis, that is, you are still not sure whether the cause of acute illness is actually an infection, then if it is just a sepsis, you still have the luxury of time. Then you give the first dose of antibiotic maybe within 3 hours. And during that initial 3 hours of time, you have to do a battery of tests, a more focused clinical examination, just to check that, yes, it is a non-infectious cause of acute illness that is there. But if the patient is in a state of shock, then you do no delay. You do not have the luxury of time. You have to give antibiotic within 1 hour. So be it possible sepsis or probable or definite sepsis, if it is a septic shock, the patient is in a shock state, then the first dose of antibiotic has to be given within the first 1 hour of arrival in the emergency. But if it is a probable sepsis, and it's still you have to give antibiotic within 1 hour. But if it is possible sepsis, that is may or may not be sepsis, then you still have the luxury of time of maybe within first 3 hours you can give the first dose of antibiotic. So this also they have kept intact from the last guideline that I'm talking about, which came in 2021. So these recommendations remain same from the last guideline. Blood lactate levels are very important because they give you an idea about the peripheral tissue perfusions, because whatever is happening, you're looking down up to the tissue level, whether those mitochondria are working well to generate those ATPs, those powerhouse to keep the cells working. And as I told you that there are some subtle changes which has happened in this guideline. As I told you that everything has to be individualized. So you just cannot give 30 mils per kg of IV crystalloid bolus to each and every of your patient. What happens to a patient who comes with in a state of maybe end stage renal disease on maintenance hemodialysis? What happens to those patients who have poor cardiac function, an ejection fraction of maybe less than 30%? And you cannot just simply load those patients with 30 mils per kg within 3 hours, because the patient is going to die if you overdo those resuscitations. So everything has to be individualized, and this individualization has to be based on patient characteristics and the clinical context. What are the chronic comorbid conditions that the patient has? What is the current medical history? What are the drugs the patient is taking? So these things become very important when you are trying to individualize the resuscitation status. And at the same time, what is important is whether the patient is obese or non-obese. So if the patient is obese with more than 30, the BMI of more than 30, then in that case, you actually using that 30 mils per kg has to be actually on the basis of an adjusted or an ideal body weight if the BMI is more than 30. Apart from that, the fluid volume is calculated on the basis of actual body weight only. And remember, it has to be a frequent ongoing reassessment and close monitoring, so that you do not overdo and you do not underdo. So all the time when you are filling up your patients with volume, you have to check those dynamic measures of fluid responsiveness just to understand whether your patient still requires more volume, whether your patients are going to benefit out of more volume. So it's a frequent ongoing reassessment that is very, very important. So overall, the good practice statement is that we know that sepsis and septic shock are medical emergencies, and that resuscitation treatment should begin immediately, but it has to be individualized based on individual patient characteristics and the overall clinical context. I hope I'm clear. So coming to the hemodynamic management also. So what happens is after the initial fluid resuscitation has been done, whether to go for a restrictive or a liberal fluid strategy. Two very important trials came in after the last guideline, that is the classic trial and the Clovers trial, and the results were murky because they could not tell us whether the amount of volume that you need after the initial resuscitation phase is over, whether the restrictive volume or a liberal fluid volume is going to benefit the patients. They found no mortality benefit in both the arms. So what they told is that it again has to be individualized, and it has to be individualized based on the patient's clinical characteristics as well as certain health system factors. And by that they mean whether availability of monitored beds are there or not. Because whenever you are opting for a restrictive fluid strategy, it means that to correct hypotension in the restrictive arm, you need to give more vasopressors. So whenever you need to give more vasopressors, the patient has to be monitored very closely. So availability of monitored beds also has become very important, and that has been highlighted in this latest guideline. And at the same time, as I told you, chronic illnesses, for example, whether the patient has got a heart failure in the background, if it is a patient of chronic heart failure and ischemic heart disease, ischemic cardiomyopathy, etc., chronic kidney disease, etc., on maintenance hemodialysis. So in those cases, obviously, instead of liberal fluid, you will definitely opt for restrictive fluid. So these things become important, and that's how you individualize. You make it a personalized approach rather than a broad layout that has been given by the guideline itself. And as I told you that these days we do not look at the CVP at all, because CVP is a static measure of dynamic fluid responsiveness. These days, we are relying more on the dynamic measures of fluid responsiveness, that is the passive leg raise, and a stroke volume variation or a pulse pressure variation. So if you have the luxury of a cardiac output monitor, just by giving fluid channel challenges, small fluid challenges, if there is a difference in the cardiac output of 10 to 15%, you know that your patient is still volume responsive. And you can do the same by mimicking a rise in the preload by doing a passive leg raise at the bedside. And if the cardiac output increases, or if there is an increase in the blood pressure, you know that your patient still will require more volume. So your patient is still volume responsive. So these are all dynamic measures of fluid responsiveness. There is one more tool for intensivists which has made intensivist life very easier. That is a quick bedside echocardiography. You check the IVC diameter and collapsibility, and based on that, you can judge how much more fluid can be given to your patient. So these dynamic measures have become very important. What they have told, that I've just mentioned about cardiac output monitor, but they have said the guideline tells us that there is still insufficient evidence to make a recommendation whether you actually need a cardiac output monitoring. This is actually done very, very minimally invasive, because you just need an arterial line in place, and then just by analyzing the waveform morphology, the arterial waveform morphology, they will tell you about the systemic vascular resistance and all this cardiac output and stroke volumes and the pulse pressure variations and stroke volume variations. This can be done by a minimally invasive cardiac output monitoring. But the guideline tells us that it is not necessary to hook on every patient to a minimally invasive cardiac output monitoring. There is insufficient evidence, because no mortality benefit has been found in even those who has not been given this kind of monitoring. So if you get your basics right, you know that you have won the job. So that is very important. And serial lactate monitoring is obviously very important, because you need to show that there has been a decrement in the level of lactates once you have started resuscitating the patient. But having said that, this is very important to note that do not continue fluids until lactate normalization is achieved. Because if you try to normalize, if you try to pump in more fluids till the time the lactate levels are normal, you may be overdoing certain things, because there may not be new lactate generation, but there can be poor lactate clearance, because it is the liver which clears the lactate. In a background of a multi-organ dysfunction, the liver function may be deranged, for which the lactate clearance may take some time. There may not be new lactate generation, but there is poor lactate clearance. So these two things are very important. So if you just simply keep on looking at an elevated lactate level and keep on infusing your patients with fluids, you may be doing more harm than good in your patients. So this is very important. Now, something very important that has come up, particularly when this path breaking trial got published in JAMA in 2018, that was the Andromeda shock study. And that told us that in resource limited setting, where you do not have the luxury to monitor lactate, or maybe you are doing things in a very financially constrained manner, where you cannot keep on doing repeated ABGs, then you can guide your entire therapy, your resuscitation therapy, based on capillary refill time. So one capillary refill time of less than 3 seconds means that the peripheral tissue perfusion is well maintained. So but this guideline has suggested that you can just monitor the capillary refill time if you do not have the luxury of monitoring lactate uh, uh, at least 2 to 3 times in a day. You can just keep monitoring the capillary refill time. So that also will give you a very good idea about your peripheral tissue perfusion. So CRT is doing is almost having a non-inferior kind of a result with lactate. Now, coming to blood pressure, as I told you that in septic shock, the initial MAP target is about 65 millimeters of mercury, and it is always recommended to maintain a MAP within a reasonable range of 5 millimeters, which means 60 to 65 or 65 to 70 may be the range of MAP target that you need to achieve, because it is very, very difficult to keep the MAP static at 65. It will keep on fluctuating. The limit of fluctuation should be within 5 millimeters of mercury, and you titrate your vasopressors accordingly. But what is most important is that there is no benefit in targeting higher MAPs. Do not target higher MAPs of 80 to 90 millimeters of mercury, because all these vasoactive drugs, this is very important, that all these vasoactive drugs like like noradrenaline or vasopressin or epinephrine, whatever you're using, they are all arrhythmogenic. And more so in the elderly population, patients who are still a little bit volume depleted, so they are arrhythmogenic. And particularly in the background of a dyselectrolytemia like a hypokalemia or a hypomagnesemia, these drugs itself can cause arrhythmias. So do not target a higher MAP. So any MAP of 60 to 65 or perhaps 65 to 70 is good enough to maintain peripheral tissue perfusion. And particularly so, as I told you, in the elderly generation of more than 65 years, it is better to keep a MAP of 60 to 65 rather than targeting a higher MAP. So this has been well documented in two trials. One was done way back in 2014, the sepsis-PAM trial, which told us that if you target higher MAP with vasopressor, you are actually subjecting patients to a higher risk of atrial fibrillation. So in the arm where they targeted a higher MAP of 80 to 85 millimeters of mercury, those were the patients who had all these dysrhythmias. So do not target higher MAP in your patients. But an interesting observation was in a subgroup analysis, they found that there was 10.5% absolute reduction in renal replacement therapy, requirement of renal replacement therapy in patients in whom a higher MAP target was kept. And they were the ones who had chronic hypertension, but not very well validated. And that's how the recent guideline of 2026 tells us that do not target a higher MAP. Now, even the last trial that we got to see, that was the OPT-PRESS trial, which came in 2025, they also told that there are chances of higher mortality in patients in whom a higher MAP of 80 to 85 millimeters of mercury were targeted as compared to the conventional group of 65 to 70. And there were lesser number of free days of organ failure, vasopressor and ventilator and RRT. So there is no point in targeting a higher MAP. Early antibiotic, as I told you, is very important within 1 hour of recognition. And if it is a septic shock, be it probable sepsis or possible sepsis, since it's a shock state, you have to give antibiotic within 1 hour. But if there is no shock, then in probable or definite sepsis, probable or definite sepsis, you have to in probable or definite sepsis, you have to give antibiotic within an hour. But in possible sepsis, you still have the luxury of giving antibiotics within 3 hours. But utilize that time to check whether there are any non-infectious causes of acute illness that is causing the problem in your patients. So close monitoring is very important in patients who have a low likelihood of infection and if there is no shock. So this is very well validated in the current guideline. And the good practice statement that has come out is that in possible sepsis without shock, the clinician should perform, as I told you, a rapid assessment, infectious versus non-infectious causes of acute illness. So this antibiotic timing that has been shown here has been kept intact from the last guideline of 2021, that do a rapid evaluation and give the first dose of antibiotic. If it is a shock, be it probable sepsis or a possible sepsis, if it is a shock, antibiotic within 1 hour. If there is no shock, probable sepsis, give it within 1 hour. Possible sepsis, you have the luxury of time, and you can look out for other non-infectious causes. Now, giving antibiotics early has become so important. I talked about using a screening tool even during transit, your way to the hospital, either through an ambulance or through a flight. Now, what this guideline is telling us, that if you have those infrastructure in place, your screening tool has come as positive, you have positively identified a patient of sepsis and septic shock through your initial screening, then, and if you know that time to reach the hospital is more than equal to 60 minutes, now they have gone one step ahead and they have told that if a structured process is in place, give the pre-hospital antibiotic. So even before reaching the hospital, so everything has started even before reaching the hospital these days. So even before you reach the hospital, if your screening has come positive, as if you have correctly identified a patient of sepsis and septic shock, you know that your time to reach the hospital will be over an hour, then don't delay the antibiotic, you give the antibiotic. So just to make you aware of the fact that earlier in the 1 hour bundle, I told you that drawing appropriate cultures before starting antibiotic. But here, they have told you that yes, that 1 hour bundle holds true, but giving antibiotic first, if the time to reach the hospital is more, then giving antibiotic first is perhaps very important, because that is going to reduce your mortality, and that is perhaps more important than drawing the first culture sample. So give antibiotic as early as possible if you have correctly identified sepsis. Now coming to biomarkers, this is very important. Procalcitonin, as we know, that it's an expensive test, but what they have suggested that do not use procalcitonin to diagnose sepsis or septic shock. Rather, you use procalcitonin to understand, to correctly identify the window where you can de-escalate your antibiotic. You know that the patient has started responding well, so your clinical findings are getting better, and now perhaps is the time to de-escalate your antibiotic. Then use procalcitonin. So procalcitonin, using procalcitonin to diagnose sepsis or septic shock is not at all recommended, but using procalcitonin to de-escalate your antibiotic is all that is suggested in this particular guideline. So you can see that the meta-analysis of 30 studies, they showed, it's a pooled data from 3,200 patients, and they have showed that the sensitivity of procalcitonin to diagnose sepsis is around 77%, and the specificity is around 79%. And there was no difference in short-term mortality or even length of ICU stays or length of hospitalization in whom you have done this particular test, procalcitonin. It's an expensive test, but still it's a good judge for bacterial sepsis. But do not just rely on this single biomarker to diagnose sepsis in your patients. So when it comes to infection management, antibiotics are very important, and the INDICAP-2 study correctly identified that it is the gram-negative organisms which are troubling us the more in the Indian subcontinent, and most of our pathogens are MDRs now. So they are the ones who carry a very high risk of mortality, and you have to identify patients in whom there is a high risk of MDR infection. So some of the factors that promote MDR pathogen are like prolonged hospitalization, particularly in a unit which already has got a high prevalence of MDR pathogen. So with prolonged hospitalization comes the chance of secondary nosocomial infection with these MDR pathogens. Then prolonged use of broad spectrum antibiotics, then previous infection with MDR pathogen, or even colonization with an MDR pathogen. So if you get to see patients who have got this kind of a history or a clinical context like this, you know that your empiric antibiotic must have that particular drug which will cover this MDR pathogen. And that is what is being suggested in the Surviving Sepsis Campaign 2026 guidelines. So use this MDR coverage in patients. Again, this is an individualized strategy. Use an MDR pathogen coverage only if you get to see all these factors in these patients. So your clinical context matches, and now you know that you have to target the MDR pathogen. But if the clinical risk is low, do not unnecessarily waste your antibiotic resource. So this is all about stewardship. So that is very important. Same is true for antifungal therapy. Do not use empiric antifungal therapy. Do not just fire antifungals like that. Rather, it should be determined on a case-to-case basis, and look for factors, high risk cases who can have fungal infections, like again, prolonged hospitalization, prolonged antibiotic therapy, if there is a background of immunosuppression because of a disease or a therapy, etc. And if it's an intra-abdominal source of infection, obviously you know that your patients are going to need an empiric antifungal. So quickly, talking about, this is something new which has come up in this 2026 guideline, that if you think that the patient will require anaerobic coverage, then do not hesitate. You give anaerobic coverage, but do not give any kind of a drug with an anaerobic coverage if there is a low risk of anaerobic infection. So who are the ones who are going to require an anaerobic coverage? So they are the ones who have intra-abdominal infections. If there is a deep-seated gynecological or an obstetric infection, necrotizing skin and soft tissue infection, head and neck infection, CNS abscesses, or empyema. So these are some of the conditions where you know that the patient is going to require an anaerobic coverage. So fire an anaerobic coverage, but do not unnecessarily waste your anaerobic coverage if your patient doesn't have these risk factors. So this is very important. Now, regarding surveillance culture, so this is important because the guideline committee found that there is still insufficient evidence to recommend a ICU-wide surveillance sample to be taken from the upper respiratory tract, just to understand the kind of bugs that particular ICU is growing, and that is going to help us to guide the first empiric antimicrobial therapy. So the guideline committee found that still there is insufficient evidence to make a generalized recommendation on that. Source control is very important because unless you do a proper source control, and by that I mean you have to drain an abscess, you have to debride an infected necrotic tissue, you have to remove a potentially infected device, and you do a definitive source control because the antibiotics can penetrate into those infective tissues properly then. So you have to do a source control, and there has been a shift in the suggestion that has been given. In the last guideline, they told us that you do a source control as early as possible, and once the logistics are ready, when your patient is medically optimized, you go ahead for the source control. But now this guideline, because uh, time is important for us, and this guideline has given specifically a recommendation that source control should ideally be done within the first 6 hours. So this is very important. And when it comes to source control, you must choose the least invasive option, maybe an endoscopic procedure, or a laparoscopic procedure, whatever it is. So the good practice statement that comes out is that a rapid clinical evaluation has to be done, and you have to understand the anatomical diagnosis, the source of infection, so that you can go ahead for a source control. So, fungal biomarkers, again, as I told you, do not use an empiric antifungal. You have to individualize, find out the risk factors in whom you have to use a antifungal therapy. Same is true while using a fungal biomarker. So you do not just rely on a fungal biomarker to initiate an empiric antifungal therapy. It has to be considered on a case to case basis based on all these risk factors. Do not just rely on one single fungal biomarker for your decision whether or not to start an empiric antifungal. Now, another important recommendation that has come in this new guideline is a prolonged infusion of antibiotics. That is, most of our antibiotics that we use belong to the beta-lactam class. So use a prolonged infusion of beta-lactam antibiotics as maintenance dose after you have given the initial loading dose in your patient. And whenever possible, go for a therapeutic drug monitoring. So this has to be done on a case-to-case basis again. But if possible, if your lab has got this facility, do not just rely on the PKPD parameter of the particular drug that you are using. Do a therapeutic drug monitoring so that you know that the serum levels of the drug is well maintained above the minimal inhibitory concentration of the drug that you are targeting. So this is very important. Finally, de-escalation, as I told you, that you have to de-escalate based on the clinical parameters, laboratory diagnosis, taken everything together, and you can use procalcitonin here to consider de-escalation of antibiotics, but you should not be again using fungal biomarkers to guide de-escalation of empiric antifungal therapy. So de-escalation again has to be judged on a case-to-case basis. And when it comes to duration of antibiotic therapy, using a longer duration does not provide any benefit over using a shorter duration. So an antibiotic duration of maybe 7 days is good enough rather than going beyond 10 days or 15 days, unless there are some specific indications of doing so. So these are certain important points. So procalcitonin I have already discussed. Coming to IV fluids, now the balance is tilted towards balanced crystalloids. So when you are resuscitating, you should use balanced crystalloids in patients whom you are resuscitating with sepsis rather than using normal saline. And they have actually taken note of the largest trial that has been done so far, that is the SMART trial, where they found that the incidence of major adverse kidney events after 30 days were more in the normal saline arm as compared to the balanced crystalloid arm. There were more hyperchloremic metabolic acidosis happening because of renal vasoconstriction. There was increased cytokine secretion, and in some ways, it was actually promoting the acute kidney injury. So the balance is now tilted towards balanced crystalloids. Whenever you are resuscitating patients with sepsis and septic shock, use more of a balanced crystalloid. Coming to albumin, albumin again should not be used as it is. There are some specific indications, and rather they will give you some good numbers like good blood pressure levels, or maybe a lesser number of vasopressors being used, a lower net fluid balance. But when it comes to mortality, there was no difference in 30-day or 90-day mortality. And this was well found in the Albios trial of 2014. What is absolutely recommended against is using starches like hydroxyethyl starch while you resuscitating the patients. Also, you should not be using gelatins for resuscitation. So it is all crystalloids. If you wish to use a little bit of colloid, then it has to be a natural colloid, and that is albumin. And only in those subset of patients in whom you think that you have used a large volume of crystalloid and you still want to infuse some more volume, then you can use a natural colloid like albumin, more so if the patient is cirrhotic in the background. So these are some important recommendations. Coming to vasopressors, we all know that norepinephrine is the first line vasopressor agent. Once you have crossed the dose of more than 0.25 to 0.5 micrograms per kg per minute, perhaps this is the time to add on. And the second most important vasopressor that we use is vasopressin, and this has been well validated in some of the major trials. Now, even after noradrenaline and vasopressin, if the MAP levels still remain inadequate, then you can think of adding epinephrine. What about anotropes like dobutamine? Now, dobutamine is usually used in a very small subset of patients in sepsis or septic shock, where you have adequately filled up the patients, you have given the vasopressors, even the MAP target has also been achieved, but still you see that there are signs and symptoms of peripheral hypoperfusion, which means that you are actually dealing with a low cardiac output state. So they are the ones in whom, by adding dobutamine, you are actually augmenting the cardiac output so that there is better oxygen delivery at the tissue level and the lactate generation is much less. So this is very important. What is recommended against is using levosimendan, because the Leopards trial showed us that using levosimendan as an anotrop is going to increase the risk of arrhythmias like supraventricular tachycardia, and also there will be problems in the weaning trials that you're going to subject to in your patients in whom levosimendan has been used. So this is just a small cartoon to show you that what has been discussed so far. You start with norepinephrine. If the target MAP of 65 is not achieved, you add on vasopressin. Even after vasopressin, if there is a scope, then you have to add epinephrine. Consider dobutamine in patients in whom there is persistent hypoperfusion despite adequate filling up. Coming to hemodynamic, coming to the monitoring part. Earlier, we used to put in arterial lines in all our patients with sepsis and septic shock. Then came the Everduct trial, and now what they're telling that even the invasive blood pressure monitoring can be limited. They can be individualized. You use invasive blood pressure monitoring in patients in whom actually a very high dose of vasopressor is required, and if the dose is building up, in a compounding effect, it's building up, and patients who require frequent arterial blood gas sampling, and you know that non-invasive blood pressure measurements are going to be inconsistent, and on repeated assessments also you are finding a lot of disparity. So they are the ones in whom you put in an arterial line and go for an invasive blood pressure monitoring. But other than that, you can, in case of, if it's a very low vasopressor requirement, you can do jolly well with non-invasive blood pressure monitoring as well. That is very important in this particular guideline. Now, putting in central lines, well, central lines take time, so you initiate vasopressors peripherally, and it has been found to be reasonably safe, and but you have to quickly convert it to into the central line itself, because these are vasoactive drugs, and you need to have a large venous access to infuse those drugs. But do not waste your time in while the resuscitation process is on and the MAP is not getting achieved. So while giving fluids, you start vasopressors simultaneously so that you would achieve the target MAP. So in a way, you are achieving those tissue perfusion targets, so that after a certain point of time, maybe within 6 hours or so, you put in a central line and you convert a peripheral vasopressor into a central vasopressor. Coming to oxygen therapy, so the recommended targets are still quite hazy, but these days, let me tell you that we have stopped targeting 100% in our saturation levels in our patients, because hyperoxia is equally bad like hypoxia. So somewhere between maybe 88 to 92% is good enough. It's a conservative target. In my practice, usually in hypoxic patients, I keep a target of more than 94 to 95%. That is good enough. But in patients with an underlying structural lung disease like COPD, bronchial asthma, and ILD, etc., so they are the ones in whom you can target a saturation of maybe 80 to 92%. So HFNC has come up a big way in this particular guideline, where they are suggesting use HFNC as the first device if the patient is having hypoxic respiratory failure, instead of giving an IV. So this is very important. Also, what they have suggested, that use HFNC alone instead of alternating it with NIV during the course of management. So use HFNC judiciously, use HFNC as your first mechanical assistance device in case of hypoxemic respiratory failure. So this has come up a big time. Maybe the results that we got of using HFNC in COVID had a important role to play in formulating this particular recommendation. So I'm just skipping this slide. Ventilation, as we know that we start with a very low tidal volume strategy, more so in patients with ARDS. So there are certain pressure limits that we try to look at, like a plateau pressure of less than 30 or a driving pressure of less than 15. So these are all forms of lung protective ventilatory strategy, so that you do not do any further harm to the lungs, which are already infiltrated with the uh, already there are alveolar infiltrates within the lung, so there is a VQ mismatch happening, and you give a low tidal volume ventilation in these patients. And what about those patients in whom there is a respiratory failure, but there still is no ARDS happening? So in them, you can target a tidal volume of maybe 6 to 8 mils per kg of the ideal body weight. But other than that, in frank ARDS, you start with a tidal volume of 6 mils per kg of the predicted body weight. A higher PEEP is what is recommended in patients who are hypoxic because of sepsis-induced ARDS. But incremental or a decremental PEEP strategy as lung recruitment maneuvers is a strict no-no, particularly after an ART trial of 2017. These days, we have started proning patients early. So this is a rescue ventilatory strategy. And once proned, the patient has to be kept prone for at least 12 hours. 12 to 16 hours is what is recommended. And a proning should be started early to get the best of the results. What about using muscle relaxants and sedatives? Neuromuscular blockers, we do not give a continuous infusion because we want our patients to trigger the muscles to keep working. So we usually give a deep sedation if you are ventilating patients with higher PEEP. But if required, you can use a neuromuscular blocker infusion, but you have to quickly stop. Maybe within first 24 hours, you can use it, but after that, you have to stop. And VV ECMO is very important rescue maneuver, more so if you have prone your patients but still not getting the desired results. Your PO to FiO2 ratio is less than 80, then they are the ones who are suitable for ECMO. You transfer the patients early as possible to an ECMO equipped center who have got those logistics there. And that is why the patient selection is also very important to get the best results out of ECMO. Steroids, as we know that in septic shock, there is adrenocortical suppression that is happening. So you have to use steroids 200 milligrams per day, 50 milligram in 4 divided doses is something either you use an intermittent dosing or you use a continuous infusion. And once epinephrine or once your norepinephrine or other vasopressor dosage have gone up, maybe more than equal to 0.25 micrograms per kg per minute for more than 4 hours, maybe now is the time to give steroid. Blood purification techniques have been given a no-no in this particular guideline. Even polymyxin B hemoperfusion they have suggested against. They have also suggested against other blood purification therapies like hemoperfusion, high dose hemofiltration, or plasma exchanges. So these are the form of therapy where they try to remove the harmful cytokines from the circulation. So these therapies have still not been recommended in patients with sepsis or septic shock. What about transfusion? The transfusion protocol tells us go for a restrictive strategy rather than a liberal strategy. So by restrictive, I mean a transfusion trigger of 7 grams per deciliter. Although you have to individualize here as well in patients with myocardial infarction or a severe hypoxemia or an acute hemorrhage, you have to have a higher target of hemoglobin. Stress ulcer prophylaxis is very important. You have to give PPI, particularly in patients who have a high risk factor for bleeding, like coagulopathy, shock, or a chronic liver disease, or maybe patients who are on mechanical ventilation for more than 48 hours. So these are important. Thromboprophylaxis to prevent DVT is important. And whenever you're using an agent, it has to be a pharmacological agent rather than a mechanical prophylaxis, unless there is an absolute contraindication of using a pharmacological agent. And the drug of choice is always an LMWH over unfractionated heparin. There is no point in using both the therapies together. It has been found that if the pharmacological prophylaxis is in place, you need not have to give a mechanical prophylaxis as well. This is well documented in the PREVENT study of 2019. Renal replacement therapy, obviously those patients who will require renal replacement therapy because of acute kidney injury, you have to give them renal replacement therapy. But whether to start it early or delayed, there has been no difference in mortality. Even there has been no difference in mortality in the modality of choice that you use, whether it's a continuous renal replacement therapy or an intermittent hemodialysis in the ICU, the results have been same. But if it is an early kind of a renal replacement therapy, then the incidence of device-related infection has been found to be a little more. Now, quickly, last 2-3 slides. Glucose control, the target is around 140 to 180. Do not go for a stricter control of 80 to 110 because you are unnecessarily causing the risk of hypoglycemia in critically ill patients. Vitamin C is an absolute no in the current trial, that although it has got anti-inflammatory property, but it has nothing to do when it comes to mortality reduction in patients with sepsis or septic shock. Do not use bicarbonate because of a severe metabolic acidosis out of hyperlactatemia. lactic acidosis is not going to get reversed because of sodium bicarb therapy. But if your patient has a pH level of less than equal to 7.2 because of severe metabolic acidosis and acute kidney injury with an Akin score of 2 or 3, you can buy some time by using sodium bicarb therapy. Till that time, the treatment of the underlying disease process is very important rather than treating the lab value that you have got to see. Now, nutrition therapy, starting enteral nutrition is very important, and that has to be within the first 72 hours. There are some potential benefits like maintenance of the gut integrity, prevention of the bacterial transmigration from the gut, then dampening of the inflammatory response, modulation of metabolic responses, and obviously to reduce insulin resistance. Coming to long-term therapy, this is something new, and what they have suggested that you must have some kind of follow-up for patients with sepsis and septic shock. They must come back to you once the survivors are out of the ICU. They must come back to you. You must have some outreach clinic or some OPDs in the hospital so that you can continue with the physical rehabilitation process in these patients, because they are the ones in whom you get to see a lot of physical, cognitive, and emotional problems. So you have to have some structured long-term outcome and recovery idea in your patients, because the objective is now not only survival from sepsis but also recovery from sepsis. So some of the gray areas which still remains is after the Clark and the Clovers trial, the liberal versus restrictive fluids, once the initial resuscitation has been done, is still being discussed and still being discussed globally. Regarding arterial blood pressure monitoring, as I told you, after the Everduct trial, whether at all we need an arterial line in place in every patient of sepsis or septic shock is still debatable. Now, the use of fludrocortisone as a mineralocorticoid along with hydrocortisone, which is a corticosteroid, is still debatable. And what about the role of rapid pathogen detection tests like the multiplex PCRs, which we are so fond of sending these days, because you quickly get the results within the first 2 hours. But as I told you, that the Surviving Sepsis Campaign guideline has given no recommendation, because they said that there is still insufficient evidence now to give a proper recommendation about these multiplex PCR tests. So centers who have the luxury of all these tests, in my personal practice, I keep sending these tests because these tests have really made our life a little easier, because you can quickly narrow down the spectrum of antibiotics from a broad spectrum. You can quickly narrow down the spectrum. You give a targeted therapy, because now you not only know the bug, but also know the mechanism of drug resistance that the bug is showing. So these are very important. So with that, I come to the end of this particular presentation. And if there are any questions, I'll be glad to take them. If there are any questions, then I'll take them one by one, and then Dr. Megha will take over, and maybe we can finish up the session as of now.
किसी को कोई questions है? You can raise your hands also. We can unmute you for the question, or you can use the chat box to put up your queries. No questions? I think so. There are no questions from here. Okay. Thank you so much. Thank you so much, sir, for such an insightful. I think so. One question is there from Dr. Dinesh Chaudhary. Can we unmute him? Dr. Dinesh, you want to ask some question?
Yes, yes. First of all, thanks for this meticulous presentation. It's actually for mainly for the doctors who are actually treating this sepsis, especially in the ICU and the hospital setup. though I am not so much associated with hospital as because I am the geriatric practitioner and a community geriatrician. So my question to doctor, for the geriatric aspect, for the treatment of the elderly aspect, if we suspect that sepsis is going on, and we are not sure that what sort of microbiome that is aerobic or anaerobic, and you have mentioned very much rightly that if we can provide antibiotic before reaching to the hospital, so which antibiotic is preferable without knowing that it is aerobic or anaerobic? And if the pressure is so much low in that, usually in the septic shock, which we face, that pressure is so much low, in that case, what we can do during the transfer of the patient to the hospital to raise the blood pressure, if just by saline infusion is okay, and we are usually providing the steroid injection also. Usually, hydrocortisone we are given. So, what is your suggestion before reaching the hospital, especially for the elderly patient, those where we are suspecting that sepsis is going on?
This is a very good question, sir. And this latest guideline of surviving sepsis has addressed to this particular issue. So that's how they have highlighted how important it is to use a screening tool even before the patient reaches the hospital. So you as an outreach physician who are attending to that particular gentleman at his house, at his residence, so use that screening tool of News, Muse or News 2, which are very easy to use at the bedside. There are just 6 physiological parameters that you need to look at. And if the score is on the higher side, maybe 6, 7, or 8, you know that this particular gentleman is going to need an institutional care. So this is one. Next is taking a focused clinical history. Many a times the source of sepsis becomes clear to us by taking a focused clinical history. So if there is a fever, cough, respiratory distress, we know that the source is possibly the lungs. If there is a lower abdominal pain or a backache and a dysuria and a rigor and a fever, we know that the possibly the source of infection is the urogenital tract. So based on the source of infection, you can decide about the first dose of the broad spectrum antibiotic. So what the guideline has told us is that if there is a structure in place, a well provided structure in place, then only you give the first dose of antibiotic even before reaching the hospital. But if you know that the patient can reach the hospital maybe within an hour or before an hour into the emergency department, you can alert the particular hospital setup that this one patient is getting admitted, is going to get into the emergency in next maybe half an hour's time. And these are my initial findings which I have got, and possibly there is a sepsis which is there in the background. Then you just wait. So everything has to be individualized in that way. But if the reaching time is more than an hour and you know that you cannot lose on to that time, then the first dose of empiric antibiotic has to be given. Now when it comes to empiric antibiotics, this guideline tells us that think about what can be the possible pathogens. Give a multi-drug resistant organism coverage if the patient has got risk factors of multi-drug resistant organisms. For example, if there has been an earlier history of hospitalization in the last 3 months, if there has been off and on exposure to antibiotics in the last 3 months, if there has been history of colonization, for example, if there has been an indwelling device, a permacat, or maybe a dialysis catheter is there. So they are the ones who are more prone to grow multi-drug resistant organisms in their body. So in them, you give an MDR coverage. So when we talk about MDR coverage, and more so if the patient is in a state of shock, then obviously carbapenems are the ones which we usually think at in the Indian context. But if there is no shock, then I think it will be prudent if we use any other beta lactam group of antibiotics. For example, it can be a piperacillin tazobactam, or it can be a cefoperazone sulbactam. So those drugs can be given within the first hour. If you think that the reaching time to the hospital will be more, then you can give the first dose of antibiotic. This is number 2. Number 3 is talking about if the patient is in a state of shock, giving fluids at home. Obviously, you can start giving IV fluids at home, but again, you have to individualize. If the patient has got a background of a cardiac disorder, for a renal dysfunction, then you do not know how much volume to give, that too at how much time. So it is better to give just one 500 ml of bolus maybe within 1 hour, and by that time the patient is already being in the transit, so that the rest of the resuscitation process can be continued within the hospital. Talking about steroid, the Surviving Sepsis Campaign guideline has given a very specific thing, that you give steroid only when the shock is refractory to vasopressors. More so, if your noradrenaline dose is gradually climbing up, you know that there is a possibility of a background adrenocortical suppression happening, because the person is not responding to those vasopressor drugs. So you give steroid, and that you give around maybe 200 milligram, followed by a 50 milligram 6th-hourly dose. So these things are there. Everything has to be individualized. This particular document is this guideline is an excellent document to understand that how everything has now become personalized and individualized and contextualized. Everything has to be taken in that light. So you just cannot give a one formula fit for all patients. This is a free downloadable document, sir. Everyone can download it from the Surviving Sepsis Campaign website, or maybe from the Society of Critical Care Medicine North America website. So this is a free downloadable document. It's a robust document of 74 pages, but the recommendations have been jotted down in 3 or 4 tables. There are total 129 recommendations, and we must, as physicians, we must be aware of what is the current evidence-based management that has been put through in this particular document.
Dr. Dheeresh, I hope your query has been answered. Anyone else? If you have any questions, please raise your hand. I think so. We have no questions. No questions on chat box also. Right, sir. We don't have any further questions. So thank you so much for this insightful series, sir. I think so it would be really beneficial for all the doctors, nurses, and the healthcare professionals working in the hospitals, and they would give a special emphasis on the sepsis, and they would be able to give any first line of treatment, or at least the referral for the same. Thank you so much for your insights, sir. And thank you so much to all of you for your patient hearing and joining us. This series would be available in a recorded format on our YouTube, and it would be also reposted on our social media channels. So you can go through again with the same and have your answers, have your queries answered. Now we will meet you next month with our next webinar under this series. Thank you so much.
Thank you. Thank you so much. Thank you.